So, good afternoon, colleagues, and welcome to the UKZN ECHO platform. I'm Sarila Ramklas, and I'm the manager of the UKZN ECHO outreach for the School of Medicine. Now, this platform is a collaboration amongst the School of Medicine, the KZN Department of Health, ECHO India, the ECHO Institute and the ECHO Institute at the University of New Mexico in Albuquerque. The collaboration enables specialist faculty from the School of Medicine to exchange knowledge with healthcare workers within KZN and beyond to improve patient outcomes and quality of life. So this afternoon, I'm very excited to have with us Professor Foster and Dr. Badri. And the session today is titled An Introduction and Overview to Nuclear Medicine. This session is hosted by the Department of Nuclear Medicine. The session will be led by Dr. Shona Badri, who's the head of the oncology unit at Inkosi Albert Mutilli Hospital. But before I hand over to Dr. Badri to present an overview of the session, allow me to share points on video conferencing etiquette. Please ensure that your name is visible in the participant list on Zoom. Keep your microphone on mute when not speaking. Raise your hand or post your questions in the chat during the Q&A. So now I hand you over to Dr. Badri, who will introduce Prof. Foster and the overview of the session. Dr. Badri.
Thank you very much, Sarela. Very good afternoon, dear colleagues. Today, we're taking a focused look at the role of nuclear medicine, a field that often works quietly in the background, yet fundamentally shapes how we diagnose and treat disease. Unlike conventional imaging, nuclear medicine allows us to see function before structure, giving us a unique window into physiology at a molecular level. From early detection of cancer, cardiac disease, and infection, to targeted therapies, like radionuclide treatment, nuclear medicine is no longer a niche service. It's a core and vital component of modern precision-based care. And who better to lead us into this topic than my esteemed colleague, Prof. Foster. Prof. Marisa Foster is the head of the Nuclear Medicine Department at UKZN. She also serves as the president of the Colleges of Nuclear Physicians, where she is also a convener, examiner, and senator of the CMSA. She is the secretary of the International Society of Radio-Labeled Blood Elements and the chair of the International Scientific Steering Committee for Nuclear Medicine. She has authored and co-authored more than 120 peer-reviewed publications and continues to supervise master's and PhD students. Without further ado, I'd like to hand you over to Prof. Foster with a reminder to please post any questions that you may have into the chat session.
Good afternoon, colleagues. Sorry for the slight delay due to technical issues. And thank you so much for the kind introduction and for this wonderful opportunity to talk to you about something that I'm truly passionate about. I also think it is, in my humble opinion, the hardest discipline out there. So allow me to just dive right in. Just to provide a short overview as to what I'll be speaking about. just a brief explanation of what is nuclear medicine. Dr. Shona Battery has given such a nice summary that I can almost skip that. And then I'll highlight some of the more routine indications that you can use in clinical practice and highlight some of the more exciting research possibilities that we have. And so if we think about an airport, something that we're all very familiar with, we can see the structure of the building, we can see the runways, the towers, the coffee shops, we can see the structure from outside and if there's any big damage from the outside. What we cannot see is what's happening inside. How busy is it? Is the coffee shop empty? Are there queues in certain areas? So we don't get a sense of what is happening inside if you're just looking at the structure. And so in the same way, radiology gives us the architecture and the structure from outside of every organ. But when we want to look at the metabolism and the physiology and the receptor expression, perfusion, etc., then we have to call on nuclear medicine. And of course, you don't want to look at either one in isolation. So the best is to combine both fields into one imaging modality. And so if we look at what we have to image with, so we have SPECT cameras and we have PET cameras. And this is just depending on what we've injected into the patient. So unlike radiology, where you have a camera that emits radiation throughout the patient from outside, we in nuclear medicine make the patient radioactive so that the camera just detects the radioactivity which is emitted from the patient. So depending on what we inject, let's say we take a technetium-based pharmaceutical, then we use a SPECT camera. There's an image of a typical SPECT camera. So that means single photon emission computed tomography. So it just tells you that I've used something which only emits a single photon, and therefore I need to use a SPECT camera. And this is often fused with a CT for SPECT CT. So to give you both the morphology and the functioning. On the other hand, if you use something like F18 FDG, which is a PET tracer, it emits a positron. So PET is positron emission tomography, and therefore you need to use a PET camera, which is this one in the top right. So other than SPECT imaging and PET imaging, we can also treat patients. And for that, we can use either an alpha particle, a beta particle, or an Auger emission, just depending on what we want to target and what kind of disease it is. So then where can we use nuclear medicine? If you look at the infographic and the stats that are displayed there, you can see that there are over 60 pathologies that can benefit from either diagnosis and or treatment by nuclear medicine, and that over 30 million people benefit globally from nuclear medicine imaging and treatment procedures. So if you take it from top to bottom, you can see that there is almost not a structure that we cannot image with nuclear medicine. And if you look at the orange bits, those are the ones where we are able to even offer therapy. So you can see the thyroid, we can offer for prostate, for neuroendocrine, and this list continues to grow. And if you look at this, just the statistic here, you can see that when you finish reading that, 200 people would have benefited from nuclear medicine somehow. So the short answer as to where we can use it is really everywhere. And so now we look at the global priorities. So where are the biggest diseases? And where should we therefore focus our efforts most? And if we look at non-communicable disease, we can see that cancer and cardiovascular disease contribute the most to global morbidity and mortality. The red areas there are the cardiovascular, this is TB. And then if you look at the non-communicable, or the communicable rather, we're looking at HIV, TB, respiratory diseases, gastrointestinal diseases, and malaria. And this is where we should focus most of our efforts. If we break this down into gender, male and female, you can see that it's very similar. The females just having a slightly longer lifespan, but also the major contributors remain cancer to morbidity and mortality and cardiovascular diseases. So hopefully most of you have come across some of these fairly routine and basic nuclear medicine investigations. At least I'm hoping that most people would have seen a bone scan that you can see here. And so this is where you suspect metastatic disease in a cancer that goes to bone. And here we want it to be osteoblastic mets. So you'll choose the cancers that tend to give you osteoblastic metastases, because the lytic ones we might see, but we might miss them. And often something like FDG PET would be better, and replacing these indications more and more. We could also do some non-malignant investigations like metabolic bone disease, even sometimes some sports injuries, stress fractures, etc. For thyroid, we commonly ask to confirm Graves' disease. We can also look at multinodular goiters. And we can then subsequently also treat them with a different kind of radioactive iodine. This is an example of a renogram. And here it's always good to phone your local nuclear medicine department and speak to someone, because we often get requests for obstruction only, or a MAG3 or a DMSA. And it's always better to speak to your nuclear physician to hear which information do you need, and what investigation would be best suited to that. So we can offer MAG3, we can offer DMSA, but it all just depends on what the question is, how to help you best. And so then looking at the importance of cardiovascular investigations. So we do what we refer to often as MIBI scans or MUGA scans. MIBI scans is actually myocardial perfusion imaging. And here we look at really just the perfusion to all the parts of the left ventricle. And this gives us an idea of whether there's ischemic heart disease. So this investigation has a very high negative predictive value, meaning if we give you a normal result on the myocardial perfusion imaging, there's a less than 1% chance that that person will go ahead with a cardiovascular incident in the next year. So in that way, we can gatekeep angiography, for example. On this, in this image, you can see the contractility of the left ventricle, and this we often use before giving something like a cardiotoxic chemotherapy. So we have a baseline contractility, or EF, and then you can adjust your dose, or even withdraw if you see that there's some toxicity to the myocardium. You can also imagine, so on MIBI, we can't see the difference between myocardium that's hibernating or that's dead. And in that case, we would do a viability study. So you'd ask for an FDG viability, and then we can tell you, is it worthwhile intervening? Because you can imagine if the cardiac muscle is dead, there's really no point in wasting all of the resources and time to intervene with an angioplasty or similar intervention. And then also we can do lots of interesting research on vulnerable plaques, inflammation, and infection. But those are not likely to come into clinical practice anytime soon. This is also just a nice research option where we can look at gallium-68 FAPI to see is there dead tissue in terms of viability. So we're looking at fibroblast, which is imaged, and we can see if that tissue is alive or not. In terms of CNS, we can look at dementia, and we can classify that for you in terms of what it is likely to be. We can characterize and diagnose Parkinson's disease. We can look at seizures, so we can identify, as you can see in that very small picture there, we can identify where the epileptogenic focus is, and that can be removed. Brain death, and then a few other more research-related indications. This is some researchers fused the nuclear medicine imaging with MRI images, and they looked at a patients that had COVID infection. And they saw that even 6 months later, there was still significant neurological deficits in the brain, changes in how the brain functions after COVID infection, which is quite interesting. Then we also look at some emergency investigations. So if you suspect a pulmonary embolus, you would send for a VQ scan. And in that case, we need a fairly recent clean chest X-ray, and we need the Wells score, the Wells probability from the referring physician. So this should really be asked when you want to change your management. So if you've already decided this is high and you started treating, then that is probably not the best patient to send for a VQ scan. Similarly, we can look at a gastrointestinal bleed, which is actually far more sensitive and accurate than most radiology procedures. We can look at post-renal transplant, whether the transplant is functioning well or there's any risk of rejection or any surgical complications. We can diagnose testicular torsion, and we can also look at something like cholecystitis or a biliary leak, and those are considered more urgent or emergency investigations. Coming to cancer, which is the major contributor to morbidity or mortality like we've seen, it would be important to have an investigation which stages and restages patients. So we know that the vast majority of cancers have high glucose metabolism, and therefore we use something which is similar to glucose, a radioactive type of glucose, fluorodeoxyglucose, and we inject that into the patient, and then we can do a whole body staging. As you can see, all of the very bright spots indicate exactly where the cancer has metastasized to. And this is very useful for if you want to do one investigation that stages the patient completely. You can restage and you can predict treatment response. Let's say you start the chemotherapy and you're not sure that it's actually working. After 1 or 2 cycles, you can do a PET to see, is this treatment working or should I rather switch to another? And in that way, you can actually save the patient some side effects and avoid unnecessary costs for something which is unlikely to work. And so we also have new traces available all the time. When we look at prostate cancer, for example, we use something called gallium-68 PSMA, and that targets specifically the PSMA expression in these cancers. But FDG is the major workhorse for PET imaging. Of course, we can also look at infection and inflammation. Yeah, I would say the most clinically useful indications would be for something like fever of unknown origin. So instead of subjecting a patient to weeks of investigations and all sorts of interventions, you can do an FDG PET, and we are likely to localize where the infection is from. We can also use it in vasculitis, in TB, if you want to know, because we often arbitrarily use 6 months of treatment or 9 months, so we can detect extrapulmonary TB easily, and then we can say that this patient probably needs more treatment, or you can actually stop the treatment now to make it far more individualized than just an empirical 6 months or 9 months treatment. You can see in the center that there are multiple targets that we can use to image all types of inflammation and infection in clinical practice. So then coming to something that is quite important in nuclear medicine now, where we combine first the diagnostic scan with then a therapy. And much as this is considered new, this is something we've used in thyroid carcinoma. This is actually one of the very first applications where we used a type of radioactive iodine to image the thyroid cancer, and then just went ahead and changed the isotope slightly to change it from an imaging isotope to a therapeutic isotope. And in that way, you can now, you see the cancer and then you know where to target it and how to fight it, basically. So if we look at these 2 patients, both of them have neuroendocrine tumors. But if you image this one to see whether there is somatostatin receptor expression, you can see that it's just a normal scan. There's nothing negative for the target. And such a patient should then be sent for conventional therapy. On the other hand, if you now see that the somatostatin receptor is overexpressed everywhere like this, and it's more intense in the liver, these patients we can now treat. And we changed that gallium-68 that we used to image on PET, and we just swap it for lutetium-177, and now we get to treat the patient. And instead of just giving a systemic treatment that goes everywhere, it goes to exactly these areas where we saw the metastatic disease on imaging. And this is just a schematic to show that we find the receptor and we bind it to something to make it radioactive so that we can either image or treat. And if you look at these statistics, it's very clear that worldwide there's a huge interest in these therapeutic radionuclide therapies. And this is probably where the future of oncology is. And so we have a few tools. We can use something that emits an alpha particle, which is basically like a helium nucleus and travels a few cell widths in the patient. And this is like a bomb really to the tumor. So this causes double-stranded DNA breaks. Then we have sort of a lighter version, which is a beta particle, and travels further through the patient, but doesn't give so much damage, so causes single-stranded DNA breaks only. Then we have X-rays for comparison and gamma rays, which we use for the imaging part. So we select the most appropriate based on the tumor. I'm going to try and show you a video here. I'm hoping it's going to play to just make this a bit more concrete and not just theory, but yes, there it goes. So, of course, the radiopharmaceuticals are not colored like it is there. It is a colorless thing. Then you can see we need a chelator to connect to this microscope. So the beta particle attacks the tumor and the gamma ray makes it visible to this tumor. So you can see this is usually just a simple injection. For this one, we usually put it in a 50 ml bag and it runs over a few minutes. And you can see it's attracted really like the GPS to the tumor. It goes directly to the tumor. And once it binds, it's internalized into the tumor. As it binds, it goes into the tumor. It's like a detonation. Causing cell death of the tumor and then shrinkage as a result. So the nice thing is, because there's that gamma emission, we can afterwards see exactly where we have treated and to make sure that we have actually targeted the areas that we needed to target, as you can see. Okay. So just to show you some examples then, this is a patient with widespread prostate cancer. Usually on a normal scan, if you just do a gallium-68 PSMA, you wouldn't see any of these bones. So widespread disease with a PSA of 782. And then this patient was treated with actinium PSMA. This is an outpatient treatment. So we injected over just a minute or so. And then the patient comes back every second month. So waits for 2 months, comes back, and we usually treat for 4 times. And you can see from this initial picture to this one, in the course of a year, that amazing improvement where now you don't see a single bone involved and the PSA has dropped to 0.04. Some more examples where patients were actually sent home, just there was really nothing that could be done. Widespread lung mets, as you can see here. And then it just took 1 or 2 cycles of actinium PSMA and that resolved. Another patient with a brain tumor, which was also unresectable and was pretty much sent home, treated with 1 cycle of actinium PSMA, and that responded quite well. As I said, this is an outpatient treatment, and it has relatively few side effects. So patients complain of a dry mouth usually, and they can have some bone marrow suppression, but usually that resolves quite spontaneously. Then we also started actinium treatment in KZN in January of 2023. And this is one of our first patients. You can see these patients reach our department when there's nothing more to be done. Another patient with widespread prostate cancer, you can see it's everywhere, had 8 cycles of docetaxel and then was treated with 1 cycle of actinium PSMA. And you can see that remarkable response. just one more that I want to show of a young patient. You can see 28-year-old female with, she had a thyroid cancer and significant lung metastases. Also, we did not have any second-line therapy available for her, so she ended up with us. We imaged her and treated her, and you can see there's quite a good response in terms of that lung metastatic involvement. This is probably the future. So we need to work with our oncology colleagues very well. We have to see when do we need chemotherapy, when do we need nuclear medicine, and co-manage the patient. So we very much need a multidisciplinary approach where specialists come into play when they almost need it, and then we co-manage these patients. This is just a picture of our consultants and some of our radiographers in our department. I've used this one because I thought if you want to see our faces, you'll have to come and visit us at our department. This is a very friendly bunch. They'll be happy to help. You can see the alphas are the consultants, the betas are the registrars, and the others are the technicians. But they're very willing to help. They're a happy team, and they will welcome you to our department. Before I end this, I just, over the weekend, was notified that our department is now accredited by the ICPO as a Center of Excellence for Theranostics for endocrine neoplasia and prostate cancer. And I just thought I'd share that here. Thank you so much.
So thank you, Dr. Costa. What an enlightening presentation. I tell you, it's like the best kept secret. All right, so I'm going to hand you over to Dr. Badri, who will open the floor for questions. Please raise your hand and unmute, and Dr. Badri will host those questions. There's a comment there from Dr. Garbers.
Okay, so I'm going to read the first comment from Dr. Garbers. Thank you for the informative presentation and visuals. Does South Africa produce these tracer medicines, or do we import them from overseas? Are the traces broken down in the body and then eliminated later? And thirdly, are there dangers when the incorrect dosage is given, for instance?
Yeah, thank you for that question. So we do produce some of the traces in South Africa, and others we have to import. Like the actinium, for example, we do not produce here, but we have to import it. And as with any medication, if you give the incorrect dosage, that is a problem. So it is most of them are excreted via the kidney. So it's a renal elimination. And so we also give them lots of fluids before to make sure that they excrete them quite quickly. And we ask them to drink lots of water to facilitate that renal excretion. So it is, in that sense, it is broken down in the body, eliminated. Yeah, I hope I answered that.
Thank you very much, Dr. Foster. I'm not a doctor yet, so it's first year pharmacy. I'm very happy to be able to join in this conversation, and it's really informative. We're not on the nuclear medicines yet, but I can see it's a fascinating field, possibly for later study as well. I appreciate it. Thank you.
Thank you so much for that.
There's a hand up by Dr. Wilson. Go ahead.
Hi, I'm sorry. Can I go ahead and speak?
Yes, we can hear you.
Thank you very much for a very interesting presentation. I was fascinated by how these radionuclear studies might be able to inform on duration of TB treatment. And I didn't quite catch how it would work in this situation. So I was wondering if it's possible at all to just maybe briefly run through that. And if it's a bit too technical, maybe we could do it another time. So I'll leave you to make that decision. And I have another question. I have another question. You know, I know there are two parts to the radionuclear study, the tracer that you use. The one is the emitter that gives off the relevant waves that you detect, and the other is the carrier molecule. If you could just explain how those two work, and I think that's the essential basics of nuclear medicine, I'd really appreciate that.
Yeah, sure. I'm sorry that I didn't make that clear because it's actually on one of my slides. So we have the one part which is the part that's gonna bind to a receptor, which is a peptide usually. And then we have a chelator, just something that holds it on the one hand and holds the radioactivity on the other hand. So bringing them together. So we have something like gallium-68, for example, making it radioactive, or technetium making it radioactive. There has to be that component that makes it radioactive for the camera to see. So that's the one arm. Then there's a chelator or something that binds. And then on the other hand, there is a peptide usually, which binds now to a specific receptor and is guided. So the receptor determines where it's going to go, and then we make it visible with the radioactive isotope. And that isotope we can swap to a therapeutic one as needed and where this is possible. So apologies for not.
Is there a name for the carrier? I mean, no, in general terms. I'm talking about a generic name. Is it just called a carrier, or is it what is it called?
So it depends what we want to target. So in the case where we look at prostate cancer, for example, we use PSMA, and that is a peptide. But if we're looking at neuroendocrine tumors, we substitute that for somatostatin receptor antagonist. And then that is the carrier to the area of interest. Is that clear?
Yeah, no, thank you very much. That's very clear. The TB, but is it a bit too technical?
We can definitely continue this conversation, but just to briefly state that we've recently, I'm just going to speak about a recent example because it is very much research related. I don't see many people using this in clinical practice, but in clinical practice recently, we've had a patient where after 6 months of treatment, we repeated the scan and we could still see it improved. It definitely improved, but we could still see areas of active disease. And if you were to leave it now after 6 months, that would just flare up again. So the decision was made based on the PET scan to continue for another 3 months. So in that way, it could direct you in which patients you need to continue for longer and in which ones you can probably stop. So if we had seen that all of the lesions had resolved, we could probably have stopped at that point.
So what's the carrier in that case, the carrier that's used?
So we used FTG, which is just the radioactive glucose. Because TB looks like cancer pretty much on an FTG PET scan. You can hardly distinguish the two. It really acts like a malignancy in terms of glucose use and uptake of FTG on a PET scan.
Got you. Thank you very much.
I'm happy to take this discussion further offline with you, definitely.
Certainly. Thank you so much.
Sure.
There's another question. Marco, sorry, I can't see your full surname, but you're welcome to go ahead.
Good afternoon. Thank you very much, Prof, for the very interesting presentation. On the practical side, I don't know if maybe I missed that on your presentation, which types of cancers can be treated with nuclear medicine, and also who makes, I guess the oncologist makes a decision as to who goes to you. I'm based in a rural hospital, so I'm just trying to see what practicality, in practical sense, what might be applicable to our patients here with us.
Thank you so much. Yeah, so for now, we still have a limited range of evidence-based cancers that we can treat. So we have a long track record with thyroid cancer, so that we are well versed in. We can treat neuroendocrine tumors with great success. We can treat prostate cancer with good success. But that list, we can also if there's predominantly liver tumors, we can target those with SIR spheres with an interventional radiologist. But the list is growing. It's expanding more and more as the research grows. So there's a lot of research going on in every cancer that you can think of. So in time, with enough evidence, this list will continue to grow. But for now, it is thyroid, neuroendocrine, prostate, liver convincingly. The rest to follow. Was there another question? Sorry, I forget now.
I think that was good. And then while we're just waiting for more questions, I can certainly testify. When I joined oncology, I didn't even know what nuclear medicine had to offer. And now, to be honest, I don't think we can practice oncology without nuclear medicine. So, for example, if we look at the commonest cancers that we see in our environment, for the males is prostate cancer. 10 years ago, you diagnose a prostate cancer, and staging was limited to a bone scan. Fast forward, and now our patients are being staged with PSMA scan, which adds a whole new dimension to the information that we're able to provide a patient with before we start treatment, from proper staging of the patient to giving them a good idea about prognosis. And as you rightfully mentioned, even patients with advanced or metastatic disease, monitoring the progress and response to treatment using these scans has become invaluable. And again, where we run short of options, we always have the nuclear medicine theranostic side to fall back on. And I'm sure, as you mentioned, the role of the theranostics is just going to keep on climbing up that ladder where we're not sort of coming to you when we've got no more options, but you're surely going to replace some of our options. Even something like breast cancer, previously we would stage with a chest x-ray, ultrasound. Now for your locally advanced disease, we'd use a CT scan. And I'm sure many of us are used to seeing comments where, this indeterminate finding seen in the lung correlate clinically. So with us, we correlate with our nuclear medicine colleagues. And that's where PET scan becomes invaluable in helping us distinguish. Maybe it's infection, maybe inflammation, maybe tumor. And I know you touched on this with TB, but for the sake of our audience, maybe if you could just give us some indication as to how to distinguish between those false positives, or how do you distinguish inflammation from infection from active tumor?
Thanks so much for that. I must first say I'm so happy to hear that things have changed so much. It really makes me happy. In terms of the false positives, yes. So FDG, of course, when you have inflammation or infection or trauma, it will also go to those areas. And here the clinical context is very important, and seeing the patient before. So our trainees see the patients before, and they do a targeted investigation and ask them relevant questions. And then, of course, you have the advantage of the CT. You have a whole body CT that comes with the PET, which people often forget. So they ask for a PET, and then later they'll still ask for a CT, or they'll ask for a CT before. And it's all in one. So you have a whole body CT combined with a whole body PET. And then if you look at uptake in an area where it doesn't make sense, it doesn't correspond to a lump or a tumor, you look at the morphological image and you use that information to see, is this more likely infection? So infection will have a typical pattern. It's difficult to just give a general rule now. But for example, in the chest, you'll get bilateral symmetrical uptake in lymph nodes, and you'll know that this is most likely reactive. Or in the inguinal lymph nodes, you'll see that they are still small, but they're taking up FDG, and this is likely inflammatory. And you'll correlate with the patient's clinical history and with the findings that you got. People tended to say initially long ago that an SUV max of more than 2.5 means it's a malignancy, which we've since shown over and over again is not the case, because something like TB that I just mentioned can have high SUV max. Doesn't mean it's a malignancy. Also, some of the malignancies like lobular breast cancer shows very low FDG uptake. And therefore, you can't use a cutoff like 2.5, for example. You have to use all the information that you have. And the SUV max is determined by a whole host of things, such as how much you injected, what the patient weighs, how you set up your camera parameters. So it's a very dangerous thing to use a cutoff on SUV as an indication. Is it malignancy? Yes.
Thank you so much for that. And I think also just alluding to the earlier question from Mampo in terms of accessing nuclear medicine. So as you mentioned, usually it's very often the oncologist that liaises directly with the nuclear medicine team. But again, Prof. Foster also alluded to MDT formats, and that's also a lot of times where the discussion comes up and the best imaging modality or staging modality is brought in. But for our colleagues that are sitting in from GP practices or the peripheral clinics, what sort of patients would you look at getting referrals from that sort of scenario? I know a lot of them come from the tertiary units themselves, but where would nuclear medicine fall in terms of direct relationship or direct communication from like a district or regional hospital to you all?
So we're actually moving away from this feeling, this perception that nuclear medicine is a specialized investigation or a discipline. It really should be, if you think about something like pulmonary embolism, it happens in general clinical practice. It's not a specialized thing. Cholecystitis, any of these conditions I mentioned, it's part of routine clinical practice. And so nuclear medicine should be seen wherever you consider radiology. There's probably a counterpart in nuclear medicine that can give you, at many times, if appropriately indicated, a better answer. So instead of just going with what you're used to and sending for an ultrasound or sending for an X-ray, undergraduate training so that people know which investigations to ask for, because we're not familiar with it and you encounter it at some later stage, and then you don't know what to ask for. And so undergraduate training, I think, will help GPs to know exactly when to request nuclear medicine.
Absolutely. Let's move on.
Just got another question.
What's the referral criteria for a patient with prostate cancer with metastases, very common cancer in rural medicine and in younger ages as opposed to older men in urban areas? That is usually due to poor health, seeking behavior, screening not done, etc. So for a patient with metastatic prostate cancer coming from a rural area, I'm assuming they want to know how can they get the patient to nuclear medicine?
So because nuclear medicine is not yet accepted as the first line, these patients will go to you. They will reach oncology. And then when you no longer have anything to offer them, or even if you from the beginning know that you have nothing to offer, that is when they come to us. But I'm sure this is likely to change, because we have seen in patients where we treat earlier, before waiting as a last resort, they do respond really well. So this is still evolving, but because the evidence is not there yet, I cannot say that a patient with prostate cancer must come to us directly. They still have to go to oncology and be treated in the conventional ways. And once you run out of options, then they come to us for now. But I'm sure this will change.
No, absolutely, I agree. So even from the oncology side, we usually provide treatment based on levels of evidence. And firstly, for the patient, even with a suspected prostate cancer, we usually have to insist that these patients are biopsied. So they have to be channeled to a urologist so that we can get histological confirmation. And I know often the colleagues are like, but it's an obvious prostate cancer. The PSA is high. He's got mets on his X-ray. But a lot of times treatment is also guided by histology, because you can have a prostate cancer. Majority will be, for example, an adenocarcinoma, but you could get other types of histologies where the treatment might be different from that of an adenocarcinoma. So that's why we often insist that patients have to come by the urologist. They have to have a biopsy, and there's certain standard of care practices that need to be instituted first in order to adequately treat and stage the patient. And usually we start off with something as simple as hormonal therapy. So that is why we usually insist that the patients come via the urology team to us. Often the urologists are also able to start them on hormonal therapy. And if we see the need, then we refer on to nuclear medicine. But again, as I agree, it's evolving and the situation is quite dynamic. And we look forward to see what the future holds from that point of view.
Professor, I have a question. Yeah. So earlier this year on this ECHO platform, we hosted the Department of Endocrinology, and they had a session on Graves' disease.
Yeah, and we were not there.
And you were not here. Yeah.
That was naughty.
So I'm pretty sure that, there are some regular people in the audience I wondered if you could extend that conversation a little bit more in terms of the management from your perspective. After the endocrinologist might have diagnosed the patient and started on management. Is there a place in
Yeah,
the
of
discipline?
course. But patients need to be aware of all the options that are there. So they must be presented with the option of having surgery or medical treatment or radioactive iodine. And they all have a role, and we have to individualize for a patient's needs. So some patients might refuse surgery or medication, or they get terrible side effects from the medication that they're getting. And then in that case, it's better to then refer to nuclear medicine because we can treat them with radioactive iodine.
I think also oftentimes the patients with Graves' disease, they usually start them on medical treatment, but continuing with it long term can have unwanted side effects. So they routinely will refer to nuclear medicine. And I think just leading on from that, a common question even our patients ask us when they receive therapeutic treatment from the nuclear medicine department, because they're counseled the way that you are getting some form of radiation that's acting at the level of the cells, and they're quite anxious in terms of precautions. Is it safe for them to go home and carry the baby? Should they be near children? So there's always a bit of anxiety around that. So maybe if you could just tell us a bit about that, just because I'm sure the practitioners out there may get this question as well from their patients.
Yeah. So it depends on what kind of radiopharmaceutical you're giving. So you look at what does it emit. So in the instance of iodine, you have a beta particle emission, but and also you consider the half-life. So it's around about a week. And so to be safe, because you are getting, for the patient, we're giving a benefit with very little risk. But the people around you, if there's still radiation from you, which happens in iodine, then they have no benefit from that radiation. So we tell patients for a week, because it's around about a week's half-life, they need to avoid other people. They need to not avoid them, but stay a meter or more away. So it's very much like COVID precautions. You spend as little as possible time with others. You don't pick up children. We advise them to, because it's excreted in the kidneys and in the salivary glands and in the sweat, they have to wash their utensils separately. They have to use a different bathroom and they have to flush twice. They sleep in a different bed. Like I said, they don't put children on their laps because they get radiation from that. But that's just for a week. And before they actually leave the hospital, they are measured by a physicist. And that level has to be acceptable before they can even be discharged. So it is really overly cautious because nothing will happen. It's just over a long-term exposure to the radiation that's not needed should be avoided. So it's not like anything will happen right there, but radiation over a long time can have an effect in terms of causing cancers in the long run.
Question. Okay, another question from Saramola Sibushi. What are the indications for sentinel lymph node biopsy in breast cancer patients? So if you want, I'm happy to start off with
absolutely.
that question. So usually we would refer a patient for a sentinel lymph node biopsy if they have early stage breast cancer clinically meaning on examination, there's no palpable and fluidy nodes. And usually these patients have an ultrasound mammogram done up front. And if there's no obvious nodes present, then these patients are referred for a sentinel lymph node biopsy at the time of their definitive surgery. Maybe you can describe the process of the sentinel lymph node biopsy.
It makes sense that you would do this early in the disease because you want to avoid just doing that whole axillary clearance, which then gives them the lymphedema, etc. So if you find with the sentinel lymph node so you need a pathologist really intraoperatively, finding that sentinel node, looking at the histology. If it's clean, then you avoid the whole axillary clearance. So you just leave the operation at that and finish. So if it's advanced, it's clearly going to have no benefit. So it's when you don't know where that sentinel lymph node is to biopsy, and then you can avoid these unnecessary side effects. So we can do either a single day procedure or a 2-day. So we inject in the region of the primary tumor, and then we make a mark on the camera as to where the sentinel node is. We image it. And then we go to theatre with a probe to show the surgeon exactly where the sentinel lymph node is, so that that one is removed, and then we check afterwards that it is the right one. And the histology should then direct further management. So it's an early breast cancer. Yeah.
I hope that answers your question, Sibushi.
So I wonder if are there any other questions? It's such a fascinating discussion, really. Yeah. So I'm just thinking about. I think it's such an efficient process as a diagnostic and therapeutic tool because of its focus. I think it's so focused in terms of what it's targeting. And it certainly does sound like it's going to have lots of health economic benefits. And perhaps we should, I don't know how we would start advocating. But,
Yeah.
So, what are your thoughts on that, Foster?
Yes. I wish I had the time to do many cost effectiveness studies. Because if you think about just something like fever of unknown origin, where you can submit the patient, they are admitted, they investigated over days and weeks, and you do so many different things, whereby you could do one investigation. It might sound expensive at that point, but it's one investigation that's done. Then you're done. A whole body investigation. Similarly for cancer, rather than doing now an ultrasound and blood tests, and you can do one investigation that might be a little bit pricey at that point, but saves you money along the line.
I hear you. I think what we forget in all of this is the impact this will have on the quality of life of the patient. You know, just knowing quickly this is the diagnosis and this is how I should be managed, rather than going through a range of tests that at this point seem a bit redundant. You know,
Absolutely.
yeah. So, well, I think we need to talk to the powers that be, and we really must actually. I think it's such advanced medicine, and as you say, it's we need to position it in the curriculum, in more than just the medical curricula, because I think there are multiple practitioners out there that can have a voice in this as well. Yeah. So, are there any other comments or questions? We really, I think Foster is available, as is Dr. Badri, to answer your questions. Prof. Musa, do you have an additional question? No?
No, actually, I don't, but I was just wondering if Prof. Foster is keen on doing some research. I mean, this is absolutely fascinating, and infections are always a huge problem. So if you have any bright ideas or you just want to get together and chat, please, I'm completely open to that. All you need to do is just send me a message and we'll make it happen.
Fantastic.
But thank you so much. It was a very enlightening talk.
I'm glad. Thank you so much.
Take care.
Thank you so much.
Bye-bye.
Thank you, Prof. As we all know that Prof. Musa is the head of infectious diseases here at UKZN. So I think that would be a very enlightening collaboration.
Sure.
Really. Yeah. Okay, Dr. Badri, closing comment?
No, I just want to thank Prof. Foster for her time. And as you said, I think the knowledge imparted has been invaluable. And I look forward to our continued collaborations as well. And thank you as well.
I'm sorry, there is one last question.
Okay, one more question. Sibushi Siramula, what are the benefits and limitations of peptide receptor radionuclide therapy for endocrine tumors?
Right. So we could be having this conversation in our department as he is there. But obviously it's more targeted. So you go exactly to where the tumor is and you leave the normal healthy tissue pretty much alone. And it's an outpatient thing. Patients go home the same day. They only come back in another 2 months. We tend to do 4 cycles. It's really, it's easy on the patient if you compare to chemotherapy, for example, or radiation therapy. So, and they have very few side effects. The side effects are really mild and they are manageable.
Well, thank you. Okay. All right. So again, Prof. Foster, I just want to say again, congratulations on your award of Center of Excellence.
Thank you. I'm still very chuffed about it.
Okay, so I just want to say again, thank you to the Hub members, and Prof. Foster and Dr. Badri for today's session. It really has been fascinating. We'd also like to thank the ECHO India team for the technical support, for the College of Health Sciences IT support, and the School of Medicine Administration. And in particular, we want to thank Professor Glover for enabling us, for enabling this platform with her collaboration with the University of New Mexico. And with that, please look out for our flyers, because I'm certain you want to have another conversation like this and you want to hear more from Department of Nuclear Medicine. And I'm sure we will schedule a further session early next year. So please look out for the adverts. And if you're available tomorrow, which I think you should make some time for, we have another session which is being hosted by the Department of Surgery on snake bites. And that will be led by the head of trauma, Professor Hardcastle. So please join us at 2:30 tomorrow on this very same ECHO platform. And we look forward to seeing you again. Thank you. Oh, please don't forget to just give us some feedback. The feedback link is in the chat. So Prof. Foster and Dr. Badri can plan our sessions in future based on your feedback and what you actually want to hear from us as well. All right, so with that, thank you very much. Goodbye.
Thank you.